Okay, and welcome back to the program. Let's go ahead and get right into the Angiovac, a tool for the removal of unwanted intravascular material, and indeed, I believe, a tool for perfusion. And one of the things that sort of stimulated me into wanting to do this program is that I have some experience with the Angiovac. Not a lot, but some. Heard about it a lot, have gone to several presentations about it, have watched cases where I wasn't necessarily doing the procedure, and it basically is veno bypass. And I've got actually a set that I'm going to bring up here a little bit later, and we're going to kind of go over the entire package. And as I mentioned, I'm kind of curious how many people out there may have experience with this already. But for those who may not, let's get into it, because I think this is something, that surprises me. I had never even heard of up until just a couple of years ago, but it's been around much longer than that. And there are some reasons for it. And as I said, it's going to be a little provocative. I think we're going to make some points here that hopefully the company that's producing this, Angiodynamics, will review this presentation and think about how this is being marketed out there. And I think it's also a message to my perfusion colleagues that we might want to start becoming a little more involved with this, because it's basically like doing a case, and a lot different than staying up all night watching ECMO. We've talked about our profession being embattled with, how do we handle everything we're supposed to be doing, or that we normally do when we like ECMO, when we don't have the manpower to do it. Like I said, I'm really hoping this is going to be provocative. It may be just a touch controversial, but I like that, and thought-provoking, and something that will become a discussion at other meetings that may be taking place, that you may take there and see what all of our colleagues are thinking about this. So, a little fact sheet. There's estimated total venous thromboemboli events in the U.S. exceeds 600,000 cases a year. So this is a significant problem. DVT accounts for 375,000 of those 600,000. PE accounts for 275,000. And the deaths attributed to deep venous thrombosis nears 300,000. That's a lot of deaths in the U.S. So, we're faced with a fairly significant problem, and I'm sure all of you have seen the advertisements on television about the IVC filters and all the problems associated with those. In fact, a number of the early cases that I did with this device were in fact for the removal of IVC filters that were completely occluded. Who's at risk? Well, the elderly, post-surgical. That's why they use those foot pumps, of course, in the ICU. Trauma patients, pregnancy. Here we go. I'm sorry. Sedentary patients who are perhaps obese. I think obesity is on there. Cancer patients. This can actually be used for the removal of renal cell carcinoma that's invaded the IVC versus doing surgery. It is an alternative, but maybe a little more complex and probably maybe off label. I really don't know. Patients who have varicosities, and 5 to 8% of the U.S. population has one or several genetic risk factors for this inherited thrombophilia, and that makes you a candidate or gives you a predisposition to DVT and VTE. So other uses of this device can be for tricuspid valve vegetations. It can be for the removal, which one of the cases that Stephanie, Min, myself actually participated in was the removal of an infected thrombus off of a catheter, an indwelling central line that needed to be removed, but they couldn't remove it because if they did, they would strip the clot off and would have had the risk of a PE. The other alternative, of course, was to go on bypass, bi-cable cannulate, open the right atrium up, take it out, take the clot out or cut the catheter and then remove it. That would have been an alternative, but it was used for that where you just went in, we just sucked it out, and then they pulled the catheter out successfully. I've actually done with, I think it was with Stephanie, I can't remember if it was Stephanie or Min, but we did a case where we removed a clot that was hanging off of the left subclavian artery and going down the aorta. You could watch it actually bouncing back and forth, and went up through the femoral artery and actually removed it. And that was a scary case. It worked out great, but it was still a very scary case. You can, of course, help to safely remove occluded IVC filters. You can have right atrial clot. You can have IVC tumor, RCC, renal cell carcinoma we talked about. And I'm sure many others of which I just don't know. I think that I think the uses potentially are much more than this, and it's a matter of the case you're presented with. And I think the more we know about it, the more we can help physicians with it. And part of that is, in fact, talking about, is this a heart surgeon thing? Is this a cardiology thing? Is this an interventional radiology thing? It's like I know all three of those people are actually doing these procedures, which I find somewhat interesting. So some considerations to think about with this device is that the catheter is 22 French. It's not really very steerable. The cost of the kit minus the centrifugal pump is plus or minus $13,000. So it's an expensive device. And you're really paying for the catheter that I'm going to show you a little later. I'll show you some pictures of it, then we'll actually look at it in close-up. So, but, what's the cost of putting a patient on bypass and doing a sternotomy, and how much time are they going to spend in the hospital and so forth to remove something? So I guess that's an offset. But, will the cost go down with more use? I don't know. You are spending a shorter time in the hospital than conventional treatment, like putting a patient on lytics. They have an occluded IVC system, ilio-IVC system. They put them on lytics, and they're dripping them all night long, trying to get everything broken up. They have a filter in them, whatever it may be, and they're in the hospital for 7 to 10 days. Plus the risks of all of the lytics. Well, if you can just go in there and vacuum this system out and get a good outcome, and then treat the patient so that they don't redevelop venous thrombus, then that seems to me to be a better alternative. Certainly, I think it is more economical than surgical embolectomy. And of course, if you have vegetation and you can suck it off of the valve versus having to do surgery and possibly replacing that valve or some other right atrial mass, I mean, frankly, I think the patient is better off. Now, at the end of this, my part of this presentation, I was hoping to have somebody, a surgeon or a physician, actually talk about some of their personal experience with it from a patient outcome perspective. I feel very good about talking about that on a somewhat cursory level. I'm really looking forward to listening to John Campbell and his thoughts on this, but no one was available. So I have a presentation from Dr. Ramchandani, who has some great images pre and post that he presented at the New Orleans conference in New Orleans. It's about a 20-minute presentation. And I think that it's very instructive and very worthwhile to sit and listen to it to contribute positively to my discussion about this today. From a technical perspective and how it works and how we use it, I feel very comfortable with that. So additional concerns, chronic fibrotic calcific clot is a whole different can of worms. You have to use it properly. Another part of our discussion today is going to be just having it sitting there is not going to do you any good. And if the physician using it isn't using it properly, we're going to talk about a procedure, a case that we did that was devastating, and how important it is to make sure that everybody on the team, especially the operator, is in fact well trained and really understands the device, because it's a great device, but if used improperly, it's either of no value and certainly has the potential to be harmful. So we've got to think about that. The other thing I mentioned was it's a big catheter, and it's a 22 French. Navigating that thing into the pulmonary artery is pretty tough. I don't think that's, when you talk about doing a PE response team where you're going to take patients that come in and they're being resuscitated and they've had an acute PE event, and you're just going to throw this catheter in them. That's I think unrealistic. Dr. Ramchandani talks about possibly, and they did it in their lab, where you do a subxiphoid incision and get control of the right ventricle, put a purse string in it, stick it in through there, and go up into the pulmonary artery. That might be a little faster, but is that really going to be faster than just going ahead and putting the patient on VV bypass and then converting to full bypass once you get the sternum open, like go do a VA ECMO and then go on full bypass and just do a typical pulmonary embolectomy? I don't know what the right answer to that is, but it's certainly a question I think we need to ask. Okay, well, let me move on to the circuit, because there's some other interesting things you could do. Here's the basic circuit. So, as I said, it's essentially veno-veno bypass. It's like doing almost like doing a liver transplant. So here you are taking it from the catheter, coming up. It goes through this filter. This is kind of a flush bag that you have here. And then here's the centrifugal pump. And remember, the system that you purchase does not include the centrifugal pump that you see here, or the console, but then it goes through the filter and then comes out and goes back into the femoral vein. Now, it could also be sucking from here and returning to here. So there can be any variation. I'm actually going to show you a really cool picture of how it can be used. And let me advance this. About how it can be used with actually an oxygenator in line. But here's basically what you're paying for. You're paying for this funnel tip. This is essentially a 22 French venous catheter, long venous, percutaneous venous catheter. But they have this proprietary funnel tip. And this thing has radiopaque markers on it and some other things. But when it's being used, they call these petals, like little flower petals, will open up, and the vortex of the blood coming through, because it's not going to completely occlude the vessel, will draw it in essentially. But once something gets in there, if it doesn't toothpaste its way through like a soft clot, which is really what this is best for, but it's a hard piece of calcium, calcific or fibrotic clot, you can easily see how that's going to get in here, and it's just going to be stuck. Now, there's a way to fix that, and I think Stephanie and I are going to have a real good debate on that one topic, and maybe John can add into this, because there is a way to manage that if that's what you're dealing with. I'll move on here. And so here's what it looks like in the operating room. In this particular case, they're using a Biomedicus pump. You can use any centrifugal pump. It doesn't make any difference. It's just this is clearly a Medtronic Biomedicus pump. But you can see the filter here There's a syringe on it here for air removal. You have this bag here for flush, and it helps a little bit for priming. There's a priming saline bag, and then there's the pump there and a clamp and going up to the field. And then everybody always likes to see what are you getting out with this thing. So these are some images of some procedures that were done, some by us, some by others, that actually have removed unwanted intravascular material vis-a-vis thrombus and arterial. There's another image, and it's pretty gross looking stuff that all of that came out. And the package comes with 2 filters. So if you completely clog one off, you get another. And I'm sure you could buy those separately as well. I'm not positive about that, but I'm sure you can. And then here is another example of stuff coming out. And here's yet another. And if you want to get this material out of there, you have to wrap a towel around it and whack it really hard with a hammer to break that filter up in order to get it. There's no easy access to it. So if you wanted to send this to pathology, that specimen, you're going to have to work for it. And then there's some more. And this is the system that I wanted to show you. So you see this they're taking to the pulmonary artery. So this is an example of where they're advocating its use for a pulmonary embolus. Now again, I'm going to show you this catheter. It's pretty robust, pretty stiff, and I think going to be real hard to navigate through this. But nevertheless, it comes through, comes out, goes down into the filter. Now look here, they're going through a centrifugal pump, returning to the venous system, but then taking some of that venous blood, coming into another centrifugal pump, through an oxygenator, and then into the femoral artery for essentially cardiopulmonary support. So, you know, that's a pretty creative looking little system as far as I'm concerned. Simple, but that's pretty good. And I think that, you know, of course, necessity is the mother of invention. So, you know, who came up with that and when, I have no idea, but it certainly was a good idea. And my suspicion is that it was a fly by the seat of your pants moment, and somebody decided, no doubt a perfusionist, that this is what we need to do to help try to save this patient. This is the presentation by Dr. Ramchandani from the New Orleans conference. He is really a very eloquent speaker, and I'm going to go ahead and play it. It's about a 20-minute long presentation, like I said, but it is very well done, and he really, really understands this from a physician's perspective. And I always learn something. I've watched this presentation 3 or 4 times, and I always learn something new from it. So let's go ahead and listen to Dr. Ramchandani, and then when we come back from the video, I'm going to have the sample up on the desk, Min and Stephanie, and we'll be able to talk about that and hopefully get the phone lines open and bring in John Campbell and have a real good discussion about this topic. Okay, let's go ahead and play Dr. Ramchandani's video.
So I've been asked to speak about the Angiovac, and let's start with a case. You've got a 70-year-old man who had a traumatic injury, spinal injury, and developed a deep vein thrombosis. An IVC filter was placed, anticoagulation was started, and an adequate INR was achieved. 2 weeks later, he had severe painful swelling of both legs and ascites, and a vascular surgical evaluation revealed bilateral phlegmasia, and a CT angiogram was obtained, which showed that he had complete thrombosis of his IVC. This is the IVC filter that's in place. Too much feedback? Yeah. So here you see the IVC filter in place, and below it, the inferior vena cava is completely clotted off. An Angiovac was used, and you see the device being placed over here from the left common femoral vein. And this is what the angiogram looked like before the Angiovac evacuation. And this is what was obtained from the inferior vena cava here. And this was the completion angiogram showing a wide open inferior vena cava. Now, venous thromboembolism is a big problem. Many of you know about this. There's over 300,000 people that die every year in the United States as a result of venous thromboembolism. It's really topped only by heart disease and by cancer. This is an example of a pulmonary embolus that is seen on a CT scan, which of course is one of the most devastating consequences of venous thromboembolism. And the pathophysiology of pulmonary embolism is basically related to right ventricular dilatation and right ventricular wall tension, both of which conspire to ultimately lead to systemic arterial hypotension. A surgical embolectomy is a traumatic procedure, and this is an example of a pulmonary embolism being withdrawn from the patient's pulmonary artery. And essentially what it involves is placing a patient on cardiopulmonary bypass, opening up the pulmonary artery and extracting the clot. Now, it's a very traumatic procedure and is usually performed in patients who are in extremis. For patients who have got less severe forms of pulmonary embolism, and even for patients who are in extremis, there was a search for less invasive ways to treat them. Thrombolytic therapy obviously came on the scene many years ago, but the limitations are that it only works on fresh clot. But all patients with venous thromboembolism will have some chronic component. And up to 50% of patients will have a contraindication because of a bleeding risk. There's about a 10 to 15% risk of major bleeding, and involves up to 72 hours infusion with repeat trips to the cath lab. Catheter treatment of pulmonary embolism, which is achieved primarily by three main means now. One is the angiojet, the other is the ECOS catheter, which is an ultrasound catheter, which has an ultrasound tip that helps to break up the clot, and the other is a pigtail. Have had modest clinical success. They use thrombolytics as adjuvants in the vast majority of them, but the mortality rates are high because these patients are so sick. And the fundamental obstacles are that these are small catheters which don't permit the removal of a large clot burden. You use a larger catheter and you lead to a lot of blood loss, which the patients don't tolerate very well. So surgical pulmonary embolectomy enjoyed a revival in the early part, in the early 2000s, really in 2002, 2003 at the Brigham Hospital. And really, prior to this, the operation was declared a failure before the incision was made, because regardless of the results, if it was successful, you would say, well, it was unnecessary, it shouldn't have been done. And if it was unsuccessful, everybody would say, well, it was futile, why did you bother? And this was usually because up until the last 10 years ago, surgeons would usually only operate on patients with PE if those patients were extremely sick, in many cases often moribund. Leishon Acklog and others at the Brigham decided to take a different approach and began operating on patients who were not in extremis, but nevertheless who had a significant clot burden with evidence of right ventricular dysfunction. Part of the rationale for this was the growing realization that chronic pulmonary thromboembolic disease was a serious problem that was being under-recognized, and the way to minimize that risk was to treat aggressively acute pulmonary embolism up front. And they, in fact, had excellent results with excellent long-term survival. And this led to an approach which is now something that is more or less standard, and that is that if patients have echo evidence of right ventricular dysfunction, even in the presence of relatively normal hemodynamics and a demonstrated central clot burden, and we'll talk about that in just a moment, pulmonary embolectomy is a procedure which is performed much more commonly now. There are two types of massive pulmonary emboli which can occur. There's the central or type A, which you see on the left over here, and there's the type B, where the clot has in fact migrated a little bit further out. And it's no surprise that the patients in the type A category will do much better with a pulmonary embolectomy as long as you don't wait till they're almost dead. Now, the lessons that we learned from catheter and surgical treatment were that these clots are large, and en-bloc extraction is critical because fragmentation sends clots downstream into the small branch vasculature and leads to the chronic effects that we talked about. But en-bloc extraction requires a large bore cannula, and the current limitation of that is blood loss. So the initial concept of the Angiovac, which was developed by Lishan Aklog, the primary author of that paper, Lishan got together with Brian de Guzman and a few others, and they actually brainstormed and came up with a concept to develop a minimally invasive targeted mechanical treatment to a local mechanical problem of pulmonary embolism. This was what the driving force was, and it's a little ironic, and you'll see why later on, but the driving force was to treat PE. So the idea was to provide all of the benefits of a surgical embolectomy without the trauma of an open cardiac surgical procedure and create a better alternative to thrombolytic therapy. So the idea was to use a large bore cannula, place suction on it to engage and remove an undesirable intravascular material, UIM, and have a trap, an emboli trap, to capture the UIM. And this was what differentiated it, to have simultaneous reinfusion of filtered blood. So they developed a large bore 22 French cannula here with a proprietary funnel tip, which opens up when a balloon is inflated using an endoflator. The balloon itself doesn't occlude the vessel, but it improves the flow rates, and it engages and conforms the material larger than the cannula ID. It's a simple veno-veno extracorporeal circuit with no reservoir. There's a centrifugal pump. I keep losing the cursor, yeah. There's a centrifugal pump with an inline filter, and it's transparent, so you get immediate visual feedback and you have real-time reinfusion of shed blood. And of course, what that means is you maintain hemodynamic stability and you preserve the patient's blood volume. They tested it out in an animal model, and even in an animal model with a right atrial embolus in transit. They did bench testing on it and showed that at up to 5,000 RPM, you had a steady increase in the flow rate without any fall off for the 22 French design. They also showed that the cannula pressures became progressively more negative as you increase the flow. And at about 3,500 RPM, they found that when you got to within 5 centimeters of the clot, there was enough suction there to just suck the clot into it. So the maneuvers are fairly straightforward. What you do is you advance the cannula up to or near where the clot is, flush the filter and repeat imaging to check your position, deploy the funnel, and then initiate an optimized flow. They received FDA clearance in 2009 for the cannula and an expanded indication just March of last year for en-bloc removal of undesirable intravascular material, as well as to facilitate flow. So they have an FDA clearance for use as a venous drainage cannula, although it is pretty unheard of to use it for just that purpose, since it's a pretty expensive cannula. and for the use of, and it's also approved for use for the removal of fresh soft thrombi and emboli. That's what the circuit looks like. You've got a catheter, you've got 3/8-inch standard pump tubing, inflow tubing, a TUI guide wire and port, which is the latest iteration of it, a Y connector up there, filter that's built into it, and a rotoflow pump with return tubing that sends the blood back into the patient. So the method of insertion is you get guide wire access to your target site, do an angiogram and or TEE, and we prefer to do both. Insert the Angiovac cannula. You can do it percutaneously versus open. It does take a 26 French dry seal sheath, which is what we use routinely. The approach can be from the IJ or from the femoral. Femoral access is preferred. And the reinfusion cannula, which we typically insert through the IJ, is a 16 to 18 French biomedicus arterial cannula. 17 French is what I typically use. Then you connect them up to the circuit, and that's what the tip looks like when it's inserted. And when you expand the balloon, the tip opens up into a funnel shape. Obviously, as you're advancing it over an introducer, you want the tip to be closed so that you don't engage the vessel walls as you're advancing it, and you only open it up when you're near the target that you want to aspirate. So let me show you a case. Well, we did 2 cases last Monday, just this Monday gone, and this is one of them. This is a photograph of our hybrid room with a Siemens Zigo system. That's Cassidy Duran, who's one of our vascular fellows, who 2 days after this delivered her baby. She worked right up to the very end. And this is the patient. This is a 45-year-old lady who had short bowel syndrome and had a central line for TPN, and over time developed a mass associated with the tip of this line and developed candidemia. She had a fungus infection, and she was extremely sick, and we had every reason to believe that this mass over here in the right atrium was a fungus ball. Very high-risk patient. She's had previous arm amputation that was done because of trauma, has short bowel syndrome, like I mentioned, and really not somebody that we wanted to operate on to remove this with an open technique. This is the setup. It's a standard setup that I showed you, and this is her on the table with the tubing setup for the Angiovac. Right femoral puncture with a 26 French dry seal sheath. Right internal jugular puncture with a 17 French biomedicus cannula, which is that's another view of that setup. Insert the Angiovac. Hook it up, and this in fact has now improved since they now have a quick connect in the latest model, which we don't have yet, which makes this part much easier. And that's what the connected circuit looks like. Obviously, you have to be extremely careful to make sure that there's no air that's trapped within the circuit. We hooked her up. This was on Monday afternoon, 3 or 4 days ago. And moments after we started, my fellow took this picture with the filter clear, and literally, and I don't have a way to show this to you because he didn't take a movie of it, but literally 3 seconds later, that's what we saw in the filter. When we retrieved it, this was this sort of fragmentary material, which in fact was shown to be a fungus ball by pathology. This is the echo that was done immediately after that, showing complete evacuation of the mass and the patient's doing fine. Now, first in man for this was done at the Brigham back and was published in 2011. And a saddle pulmonary embolism was also treated the following year at the Mass General using this technique. And I don't think this is a particularly good device for PE yet, which I think will happen. But it's ironic, as I mentioned earlier, because that was the driving force for the development of the device. And we'll talk about why it has limitations for that. Nevertheless, it has been used successfully in some instances for the removal of pulmonary embolism. This is an example of an echo of a patient in which there was a large amount of clot that had broken off from his leg and was circulating in the right atrium and was successfully removed with the Angiovac, and there it is. It's been used to remove endocarditis vegetations from a prosthetic pulmonic valve, which is a great use of this product. And here is a large right atrial thrombus, which has also been evacuated with the Angiovac. This is a catheter right atrial thrombus, and I showed you an example of that in a patient of ours that we did on Monday. Very effective for removal of that. Right atrial tumors can be removed. Tricuspid vegetations, this is from Scott Goldman at Lankenau. And this is an example of a clot that formed on an ASD closure device, which was removed using the Angiovac. So intracaval tumor and thrombus, patients with renal cell carcinoma that have extension into the inferior vena cava, not infrequently will require a major operation with the participation of a cardiac surgeon, sometimes going on cardiopulmonary bypass with circ arrest even, to remove tumor thrombus that may have extended into the right atrium. This now provides a much easier alternative to that option by removing or evacuating everything that's in the inferior vena cava and the right atrium, allowing the urologist to proceed with a nephrectomy. Very good use of it is for limb-threatening DVT, May-Turner syndrome, which is an example of left iliofemoral deep vein thrombosis, which can lead to phlegmasia, cerulean dolens, or limb-threatening venous occlusion. And this is an example of that, showing the occluded left iliac vein with the Angiovac. That's what was obtained, and the iliac vein was opened up. It's even being used now off-label in the arterial system. And this is an example just recently of a thrombectomy that was performed from the abdominal aorta. This slide is just meant to show that the patient maintained complete hemodynamic stability during the activation of the circuit because of the immediate reinfusion of any volume that was being removed. We don't have any experience of using it in the arterial system, and it is an off-label indication, but it has been used in several instances. So the spectrum really in which it can be used really are right atrial masses, vegetations, thrombi, tumor, tricuspid valve, etc. The inferior vena cava, and we mentioned examples of that. The arterial system, it has been used, very little experience with that, and we'll see how that evolves. Pulmonary embolism, I put that on there because it has been used, but I will tell you that in our experience and in that of others, the device is really very difficult to steer. It's a stiff device which has a large funnel tip, and it's difficult to negotiate it through the tricuspid valve and then through the pulmonic valve into the pulmonary arterial tree without risk of injury. There have been some modifications that have been made, and I'll show you a couple of slides that may improve that, but I think this is an area where there does need to be improvement. We were concerned and we wanted to use it for PE, so in the lab, Alan Lumsden, Brian, and Matthias, colleagues of mine, used a cadaver model and basically with a sub-xiphoid approach, put a purse string onto the right ventricular outflow tract by elevating the sternum using a hook-type device. And then advance the cannula, the Angiovac cannula, directly into the pulmonary artery by going through the right ventricular outflow tract via a purse string. And they were able to show that it's a lot easier to do that. This has only just recently been done, and we have not done it in a person yet, but the next opportunity we have, we do intend to use this technique. The product enhancements that I talked about, there have been some changes which have improved this. There is now an angle tip that is available, which is about a 20-degree angulation, which ought to allow an easier path through the tricuspid valve. We do not have access to this yet, and when we do, we'll certainly give it a shot. But I think the ability to navigate this over a wire and an introducer is really going to be the advance that will help us manipulate it around curves and into the pulmonary arterial tree. There is a working side port with a TUI insert as well, which makes things easier, and the quick connect that we talked about, which again, our circuits do not have, but hopefully as early as next week, we'll have them replaced with this, will make the whole business of connecting and disconnecting much easier. So I do think it's an important advance. It's most effective within the cava and the right atrium. It's best with, and not for pulmonary emboli, which was the driving force behind the evolution of the concept by these two cardiac surgeons. But I do think it's going to get there in the not too distant future. It's best with soft material. It does have a large bore and a stiff funnel tip, which is not steerable, even with the Hansen robot, which we have at our institution. We tried on Monday to do this, and we were unsuccessful. It makes it difficult to use for PE because of that, but a direct right ventricular outflow tract approach may be easier, although it is untested in humans as yet. We've just done it in cadavers.
Get Campbell.
I think greater flexibility of the tip and the ability to advance this over a wire would definitely help greatly. Thanks a lot.
Okay. And welcome back to the program, everybody. I'm here with Stephanie Ebus, CCP, and Min's not here yet, but he is on his way. And John Campbell, where am I looking at? This way? And John Campbell is here with us as well, CCP from Columbus, Ohio. John, how are you? Can you hear us good? Hold it. We can't hear you. Hold on. Technical complications.
There you go. You should be able to hear me now.
Yes, perfect. Okay,
Hi, John.
Perfect. Hi, how are you guys doing? That was actually a good. That was a good lecture by that physician. That was really good. I liked it.
Yeah, no, it was great. Actually, Dr. Ramchandani is a really, a very eloquent speaker and very knowledgeable. I mean, I've always enjoyed listening to him, and of course, he's over at Houston Methodist in the Med Center, and I think for any of my colleagues, that get an opportunity to go to any of the lectures that he's giving or any of the conferences that they give over there, I would highly recommend it because he really is a great lecturer and educator. So I've always enjoyed listening to him. So
he came across really clear, and I think he gave good indications and contraindications. We've never used it at Riverside for acute pulmonary embolism. Last time we had one of those cases, we just went direct CPB, circurest, and extracted the clot. I think we circurest, I can't remember, but mine was clamp. But yeah, that was actually a successful outcome as well. I think we've done 6 procedures in probably the last 6 months or so, mainly acute thrombosis of the IVC filter and so forth. But we've had pretty good success rate so far. Probably be seeing more of them in the future. I'm kind of surprised we don't see a lot more based on the size of our institution, but a lot of that's cardiology driven and cardiothoracic surgery driven. How do we see the patients? How fast do we get them? Do they decide to do them or not?
yeah, and those are and John, you bring up some really good points. Is who's owning these patients? From my perspective, I view this as a great service line that perfusion should be offering, whether you're an in-house perfusionist and caseloads are down and you're concerned about having losing staff or anything like that, and wanting to keep your numbers up. And also that is VV bypass, so it counts as a case with the ABCP. But from a physician perspective, who owns it, and how do we as perfusionists, whether you're, as I said, in-house or a business, you're running a business and a practice private, and you're looking to increase revenue and provide another service line to hospitals. What's the process?
Right. I think the majority of the patients probably show up. Trying to think of what physician, probably an non-interventionalist. I'm sorry, ICU maybe. Because it's usually it's a mechanical obstruction and then prothrombotic
Maybe vascular?
hypercoagulable state of a patient. So like, you know, it's like, what do you,
Like, what's
Yeah.
the pathway for you? Like, how does it? Who's doing your cases? Is it cardiac
Well, so-
surgery, cardiology, or interventional radiology?
actually, we have like, the way our cardiac surgeons do all vascular, and so they do all the carotids, they do, and then we have a hybrid lab. We have actually 2 hybrid labs. So how it happens in our hospital is that the interventional cardiologists that do peripheral cases, and they usually don't do a lot of cardiac, you know, extensive angioplasties. They do like leg stuff and whatnot. They usually coordinate, and that's the same with all of our thoracic stents as well. They'll use a hybrid room, and then it's usually a cardiothoracic surgeon in conjunction with peripheral vascular interventional cardiologists, and they do the cases together under angiography. And the last 3 cases I've done were IVC filter occlusions, and then last one for sure we went IJ, came down from the top, and I got 2 filters worth out of that, so that was pretty successful. The time before that, we had like, I filled 5 filters, which was a lot.
Wow.
You went through 5 filters, 5.
Yeah, on the one before this, and then
Because I had a question on this, and it says some of the IVC thrombi can be quite large. Can the system handle these large thrombi? And I put on there that the cases that I've participated in, some of them had totally occluded ilio IVC systems, and I was really
the majority of that. The lower, the iliofemoral will have the largest amount. It's like the size of your thumb or whatever. Those diameters in those veins, you can get a lot.
Wow.
And then there's additional, it says there was also mention of a backup filter, so the large ones, okay, so removing the much larger clot. So is it possible, well, I don't know if it'd be possible to do. I don't think you can put 2 filters in
Yeah,
Why
series,
not? You
can
could
you?
wire
You can't put 'em in
You could
series.
wire
You can't
it.
put 'em
You
in
could
series.
wire
Right, you
it
can
and
put
then
'em
you
parallel.
clamp out one, use the other, then switch
Okay, so that
and
would
put in
be-
another so that you could continuously.
You know,
Okay,
I don't
so-
know, half the time, I wasn't a big proponent of it. I mean, because the Angiovac guys are big on it, because to them, like, they don't, you know, they want to always be going.
That's a-
Right.
Right. So
Machine, but like, I'm like, whatever, it's just, you know, 30 seconds to change the filter. It's not, I just gotta like throw one away and put another on.
And it's not like you're on bypass where you need the
Yeah, it's not
support.
like that.
You can
Uh-huh.
come off
Exactly.
and take out the filter.
absolutely.
Right.
So
You know, then the other problem with that is, see, that with the in parallel, they think it's, I don't know, they thought it was the best thing since sliced bread. But honestly, I would just keep the original circuit and get rid of the filter. Is that it makes it heavy. So I don't know, like we have ours up on our IV pole, you know, it's gonna be closer to the field. Because that tubing length, unless you're adding on to it, is it just, you know, it's a set length. And
right, I
depending
have
on
a set.
equipment
I
you
have
in,
a
yeah,
set right here that we're going to look at.
Yeah,
Yeah.
it makes it heavy. Like we have our, you know, you've got that
Makes sense.
filter, whatever's got, you know, like a little holder. And
Right.
if you wide, and then you've got extra 3/8 inch tubing or whatever wide out on it, another filter, you get another holder for that. It's like, you know, whatever, man. You just cut the thing out and throw a new one in. It's not a big deal. And the other part was, you know, I think you made a good point earlier about who should run the device or whatnot. I would 100% say that it should be perfusion. I'll give you I can't remember the exact scenario, but the case I had 3 cases ago, or it was a while ago, it was my 3rd case ago, probably 5 or 6 cases ago for our institution, but there was some issue when they were trying to retrieve that greenfield filter, or something happened. And I had to like prime up an entire heart lung machine, and we were talking about possibly circ arrest the patient. And,
Wow.
and it was a big deal. So like, if you just have like other staff run, you know, and it goes, and we didn't have to do that, but I mean, if it would have went that route, now you're talking in a whole other gig, you know. So, and then also with the Y deal, with going with 2 filters, you run the risk of entraining. You got to really be good about air as well.
True.
With 1 filter, it's a piece of cake. But with 2, now you've got just the way that you drain. A lot of times you drain that filter down into like a side bag. And that way you can see all your clot in the filter whenever you get rid of the filter. But you have to worry about air. So air embolus, I mean, it's a venous system. It's still a risk. So you still have to worry about like make sure everything's de-aired and everything else.
Has that
So-
happened to you, John, where it
Well, we did
deprimes?
get air. We never got air to our surgical head, but what happened was that bag has a clamp on it, and you can gravity drain that filter down into the bag off to the side, and you can put a clamp there. But you can also do the 6cc syringe and push through the top of the filter to make sure it's totally de-aired, if you will, and that'll push some of that air back in your bag. I mean, if you're not careful, you can clamp it off and whatever. But and if you're not careful, when you turn your centrifugal head on, if you don't have that bag clamp, you could theoretically pull the air out of the bag and train it in your centrifugal head.
Right.
Prime you or whatever.
That
Well,
makes sense.
let me ask you this: Have you heard of anyone? Well, two things. One, I'm going to ask you this question. I want to get an answer to this. And two, we're going to open the phone lines. And what I'm going to do after we open the phone lines, because Scorpio Ray's got some really good points, and I hope he'll go ahead and call in and ask, because this guy's he's got a really interesting experience, and I think it's better to have a verbal discussion because it's somewhat complex, and we'll go over this system. But have you ever heard of any place where a non-perfusionist is doing this procedure in the in the radiology lab, for example?
No, not that I know of, but definitely not in Columbus. I don't know about other hospitals, or maybe, I guess the question for that would be then, small institutions that no longer do heart surgery but have cardiac intervention programs, as far as like PTCA and stuff. I mean, I know there's a few standalone programs like that in Michigan. Do they have standalone interventional radiology procedures, in which case they wouldn't have a perfusionist there, most likely, unless they do cell service maybe.
Right.
There possibly, that would be the scenario I would see, because I think things like we have in-house perfusion, I'm guessing they would probably do it. But
I would hope.
An institution that was small, no longer does heart surgery, but does the other things.
Because if you're trying to put an oxygenator in, or you have some other issue happen, there's a lot going, de-airing, whatever it may be. There's a lot happening on these cases. They're not that simple, but I know that that's something that we're going to have in the discussion period too, John, is how are these companies, whether it be AngioDynamics or any other company, marketing these tools. And the other thing is, I've actually seen or heard of, and I heard it from you as well, so 2 times, where the interventional radiologists want to do the procedures, but the hospital doesn't have a centrifugal pump in-house, and they show up to do the procedure, and they can't do the procedure because they don't have a centrifugal pump. And the hospital says, well, we're not buying a centrifugal pump. So the radiologists are saying, well, but I can't do this procedure without it. And they're taking those cases and going elsewhere. So if the hospital's making that decision, I understand the catheter is $13,000. I understand it's very expensive to offer medicine to anybody these days. I mean, medicine's just expensive. But as the hospital, the radiologists see it as a benefit to the patient, the cardiologists, cardiac surgeons, we do. But are the hospitals seeing something economically that it doesn't make sense? Why would they resist something like that? So, but these are all really good discussions that we have to have. Roger's going to open the phone lines. Let's go over this kit. So it comes in a box, and this is a non-sterile sample, not for human use. So you get in one container a filter, a backup filter. And here, you want to open that?
Sure.
You get one of these, you get 2 of these bags you were talking about for flushing the system with. And then you get this Angiovac circuit minus the and there's a connector here, and there's one of these things. And I know vascularly there's a lot of things that they have. The big, I forgot what they're called, Gore. They're made by Gore. There's some kind of big sheet.
The dry sheath or whatever?
The dry sheath. Yeah, and they're big.
Yeah, you got to order that separate, I believe.
Right, all of that comes from the cath lab, and I guess they give you two of these things.
They do. You can buy
and
them
then,
individually. You can buy those. They come in a little box. So
and then you have this. Yeah, and then you have this, all this tubing and all of this stuff, and it looks like there's quick connects. So this looks like a quick connect, and this looks like the part. I don't know if you guys can see this. but there's a quick
There
connect
should be like a
here.
Q valve. That's the most important thing that you got to tighten down first.
The what
And then
valve?
the rest of it- There's like a little TUI valve on the should be in there.
We talking about that?
And that's- Yeah, that's got to go in that. There's a piece that thing slips in and then it like clicks in place.
And you're talking about here?
Like you're gonna prime it. Yeah, exactly. Yeah.
Yeah, it's been a long time, huh, Joe?
Yeah, so this goes in here, and then
Exactly.
you,
Yeah.
tighten it up.
You're going, yep.
okay, there. So that goes like this.
Yeah, and then you're set, and then you get your little filter and you IV bag.
Right here. And this is where you prime it from. So this,
Well, there should be another tube that you hook in prior to the filter and then prior to the centrifugal bed. Yeah.
okay. Okay, and that's got a quickie prime on it.
Yep. And then probably hook the filter to that blue line, the blue cap down to your right or Joe to Stephanie's left, and then the other end will come out of the centrifugal. Yeah.
Right.
You go filter.
Filter.
And then, exactly.
This goes to the inlet of the centrifugal, and then it goes
Out.
back to the patient.
Yep, exactly.
So it's a fairly straightforward. I mean, it's not a whole lot of tubing,
Yeah.
if you don't know what it is. But the company is really good at sending reps. Now you're a little
Yeah,
bit.
we do.
Yeah, there you go. That looks better. You're a little bit close to the camera there. We had half your head,
Right.
and we like to see all
I'm
of.
at a desk.
Yeah, and great baseball cap. Now I know you're actually in a hotel. You're at your daughter's, which is so kind of you to be here. I even forgot to mention it. You're at your daughter's at swimmy, right? Or is it swimmy or softball?
Yeah. It's swimming, yeah.
Swimming. My granddaughter's doing swimming, so that's great. So we
Yeah,
appreciate.
Look at the swim program, man. Nitro Swim Club is like really outstanding.
I know, and it
Yeah,
makes them really strong. My granddaughter's really, got some broad shoulders. I
Yeah.
wouldn't mess. I
yeah.
think fellas are going to need to be real careful with her. They get out of line.
You
She's
should
going to hurt
see,
them.
John has a daughter that does CrossFit, and
Really,
yes.
that's
Yeah,
fantastic. Well,
she actually qualified for the CrossFit Games in August. So she's like ranked 20th in the world.
oh wow, that's
She is?
Oh, that's incredible.
Amazing.
So we do want to thank you for taking the time out of your Saturday with your family to help us with this. So let's go ahead and I'm going to open this catheter up. And let's take a look, because really this is the, of course the circuit, is, we're real interested in this, but I would say that it's a simple circuit and that any perfusionist is going to be able
I forgot where
to.
this
Yeah,
piece
you can
goes.
do that too.
That's the piece that goes to the
the waist bag, I believe.
In between?
this one, this goes to the waist bag, right?
Yeah, correct. Yep.
Right.
But
It
this
it
goes
in
here?
between the two. Yep. Exactly.
Yep.
And
so
centrifugal?
Right.
Okay.
Yeah.
Exactly.
But
So I'm gonna-
the other thing about setup, I would say, is that we use two guys to set it up just initially, and then one guy goes and does another case. Because if I need like a sterile table, you set it up, because it has to be sterile, and then they can hand it off in the field. Otherwise, I guess you could have it handed off in the field, and then make your connections back, and then prime it up at the field. We usually prime ours up ahead of time. It's just however you want to do it at whatever hospital, so.
So how many cases? You said you were doing 5 or 6 cases a month?
No, not that heavy. I mean, we probably do one a month right now.
One a
Not
month?
a significant amount. Mhm.
Okay. So here's the catheter, and basically, just the feel of it, and there's a introducer with it. Here, let's pull the introducer out. It's
Okay.
right there.
So John, Joe's always talking about perfusionists staying busy enough, finding other things to do, but I know you're plenty busy where you're working now. You don't need Angiovac. How many cases did you do last month, did you guys say?
126.
Wow.
There was 7.5 of us. We have a part-time guy.
126 hearts, right?
For 7.5
Yeah.
perfusionists?
Yeah.
Or you did 126?
No. For a month.
No, our group
All of
did in
them.
the month,
Group
yeah.
did.
In a month?
In a month.
Holy
busy.
mackerel! That is so. Did they? The introducer, I'm assuming, is just to get it through the gore dry sheath. Is that what this is for? The introducer.
Let me see.
So I'm assuming so. They must have to put this
Yeah,
in,
yeah.
and then that comes out, obviously. But this is just to get it in.
Yep.
Right.
Okay. Now I also noticed in the package.
I know our guys use that dry sheet for
there's
sure.
this piece here that must come off.
Is that part
Yes.
of the boom?
Okay, so that, and then I can
tulips
see,
out, right?
say that again?
Yeah, that's that part, and then it like tulip makes like a tulip or whatever.
Yes, yeah, exactly. The little flower petals, and you can see,
Yeah.
you can see this real close. You can see that it has, you know, radio opaque, what would be radio opaque markers on those petals. And I know if they ever collapse or don't open, then you've really got to change this catheter out. Have you had that experience
yeah.
at all?
No, I never had that experience. No.
But you've heard that same thing, that it's very
Yeah,
important that
yeah,
these funnel, that this
Makes
opens
sense.
up, right?
Right.
So-
That way it kind of like funnels it down into the catheter.
And this has a quick connect on it too. I don't know if you can see that, but now I'm having a heck of a time getting this to go through. I can't
Well,
really.
it doesn't go
I
past.
wonder if they lubricate that thing first.
Oh yeah, probably so. Now look, I can't even get it out. That's why I'm. Well, that's why I'm a
This is
perfusionist.
out of our scope.
I know.
Yeah,
That's a part of the procedure that we never.
yeah, that ain't coming. That's not coming
Really?
back out. Okay, so
Maybe-
no, but if we're ever working with a surgeon who's not used to it or hasn't ever, if you know you're in one of your first early cases,
We better
tell
practice
'em-
a little more.
Yeah, tell them not to put this in dry, because if you do, seriously, I am
That is-
really yanking, and there's
Wouldn't
probably
it be
a
nice
trick.
if I could just get it right out?
Go ahead, pull. See.
It is not.
Okay, there it goes. Okay.
All right.
It's definitely not a
Two-man job there.
You know, but it came with this, so I'm assuming you need it for introducing. And you're probably right. If it was wet, it would have maybe they put oil on it. I mean, I don't know what they do, you know, but I've seen that a few times.
You have to
So-
look
Oh,
into
yeah.
that. I'll
Yeah.
have to ask
That
one
mineral
about
oil.
that.
Mineral oil or something, yeah. So can you zoom in on this right here? So really get a good look at this if you can. And I'm gonna, and it looks like there's webbing between each of those petals. So those petals, can you see that really clear?
I don't know, but I want to see it.
Yeah.
Too bad we don't have a syringe to like. Oh yeah, it's all connected. The whole thing.
So yeah, so if you look, let me see, maybe if I use this. Can you appreciate that right here? That there's actually webbing between each of these little petals. Yeah, that's pretty cool. But looking, did you see it? Could you see it, John?
Not really, but.
Okay, hold on. Let me try again here.
But it's also
It's okay.
clear, you know. So
Oh, it's clear,
clear,
yeah.
yeah, so-
Yeah, it's hard for you to see.
It's
Oh,
basically
yeah,
all
that's
connected
right.
all the
Yeah,
way
I can
around.
see it now for sure.
You can see it now?
Yeah.
Yeah, that's really interesting.
yeah.
But you can certainly, you know, I mean, to go down here and then you'd have to get a really stiff wire through there, and then to go like this and then up this way, that'd be pretty tough to do, wouldn't it? With this, feel
I
how,
don't see its efficacy in the PA.
No, I don't either.
Situation. I mean, there's been some successful
Even just
cases.
trying to get
I think
up
the
and
guy
over.
was skilled for that, and then, I don't know.
Mm-hmm.
It's a pretty large bore, I don't know, you get that up in the PA, you put a hole through something, you're asking for a world of hurt, I don't know.
stay behind the pump, Joe. Oh, thank you, Jennifer. I appreciate it. Thanks a lot. I appreciate that.
That must
okay.
be someone you know.
Yeah, Jennifer Warner.
Let's hope so.
Yeah, nothing like having friends in this business. But Scorpio Ray, it says he won't. He haven't called in. Look, if you call in right now, Scorpio Ray, this cup is yours. I haven't even used it. Look, I'm using this right here.
Does
but
John get
I
a
haven't
cup?
even. Now, if you want a used cup, I'll give you a used cup. Okay, but perfweb.us. This will look really good on your desk. So call in. But his question, John, Stephanie, is: I am a traveler for SC, formerly Trident. I don't know what all that means. I guess that's
Yeah, I don't
special.
know.
I guess that's
What's
specialty
SC?
care. I don't know.
Oh,
specialty
specialty
care.
care.
I
Yeah,
guess.
it's probably special care.
And I have covered many IVC tumor clot removal cases. I have mentioned the Angiovac several times and have gotten indifferent responses. So
Well, I think it would be hard as a traveler to get something like that going. You know, right. Your best chance if you want to be a part of implementing it is partnering up with a surgeon, because the surgeon is the one that is going to get the consults, the cases. So at least if you partner together, you could be ready when they're ready for cases. They're going to get them and you're going to be prepared.
Yeah, but I think that's
that's all we can do. We can't go out and get cases.
No,
is he talking in difference from the guys he's working with in the perfusion departments? Maybe that's what he means. I mean, maybe I'm wrong. You know what I mean? Like he goes when he's
well, I don't know. I mean, that's why I kind of want. That's kind of why I want John to call. Or I'm sorry, Scorpio Ray.
So, Vicky was asking, is this actually a dilator and not an introducer?
It's pretty long to be a dilator.
I think so too.
That's an introducer. I mean,
Vicky,
look, it's
we
the
think
same.
it's an introducer. I don't think so either. Because it'd just be like.
I think it just needed to be wet, and it needs to come through the
And-
tip just to get this into the vessel. Then you take this out pretty low.
And I do remember
and then-
mineral oil. I think you need that.
And it probably is mineral oil.
Okay.
Yeah, but anyway, if you don't use something to lubricate it, trust me, it ain't coming. It's not coming out easy. It's going to look really bad.
I got it out.
You're going to look like you don't know what you're doing. Okay, so don't do that.
Like how we looked? Is that what you're
Yeah. I'm glad glad you included yourself.
I did.
So I appreciate that, because my favorite Min is not here. You know what? I think, if anybody doesn't know this, out there, Min is my favorite for a whole variety of reasons, but I may have to rethink my favorites list.
I mean, you were mad at me.
Oh, we got a call.
Oh, good. For men being late.
I think this is, and I'll bet you this is Scorpio Ray. Hello, you're on the air.
Hey, what's going on, Joe?
Hey, is this Scorpio Ray? Is this Ray Fleming?
Yeah.
Hi, Ray.
No, it's Ray Kubiak.
Ray Kubiak. Hey, what's going on, Ray?
Not much.
Okay, so what's you got some really, I think, provocative thoughts on here. What's your experience with this device?
Well, I was introduced to it at your meeting several years back,
Nice.
Like that plug?
and I like the design, I like the thoughts, and the ideas behind it, and I can was continually running into these cases where we would be covering them, and I'd ask the surgeon if he'd ever heard of Angiovac, and gave him the website and everything, and told him to check it out, and he was just, he'd rather just open up and do it if we had to.
But you said you were traveling at that time?
Yeah.
I feel like when you're at a hospital that people don't know you, they don't want to hear what you have done other places or something.
Yeah, I do think there's some
there's a little
resistance
resistance to like a guy coming from the outside telling us what would be good to use. I think that's probably why he's getting that resistance.
Yeah, possibly, but I think that's, I think you're absolutely right. But of course, I feel like, and I think you're this way. I think I'm this way. I think most people in our group's that way. That we're, I think, more receptive to that. I think it depends on the person, the group.
We are.
I think some groups are
I
very
think a lot has to do with
paranoid.
cardiothoracic surgeons too. The younger cardiothoracic surgeons are much more receptive to
That's true.
newer methods than some of the guys that are, within like 5-10 years of retirement.
Yeah, but I think you're or should have retired 5 or 10 years ago, because we all know that those exist too. So let's so Ray, have you done any procedures clinically at all?
What the Angiovac?
Yes. No. So, but you want to?
Oh yeah, I think it's a neat system.
No, it's exactly, and I think this is kind of a discussion that Stephanie and I had here, fairly recently. Is you look at heart surgeons. Heart surgeons they're doing carotids, which is, really normally in the purview of a vascular surgeon. They're doing fempops. That's normally in the purview of a vascular surgeon, right? They're doing endovascular procedures. They're doing stents. They're doing TVARs. They're doing, what do they call it? What do you call the doggone thing for the abdominal aortic aneurysm?
EVARs?
EVARs, yeah.
Okay, EVAR.
And TVARs, EVARs, I get, yeah, okay, yeah. Yeah,
TVAR,
TVAR, AVAR, BVAR, whatever.
Savers,
Savers, yeah.
We can keep going.
Yeah, I know.
If you want.
I get all confused with it all. But, they're doing those procedures kind of much to the chagrin of the vascular surgeons. And then you have the interventional radiologists, and they're doing this procedure. They're doing endovascular stenting, much to the chagrin of the cardiologist. They're doing it right there in
what are you about to throw out? That's what I'm...
Well, I think that what I'm throwing out is...
You're coming up with something big. I can feel it.
Yeah. I think what I'm coming up with is that, the point that we have to wait for, we have to be beholden to just what the cardiac surgeon wants, because that's been our history. I wonder if, Ray, for example, you or John or us shouldn't be going and developing relationships much in the same way the physicians do, trying to expand their referral base and the types of procedures that they're performing. We shouldn't be going and visiting with the cardiologists. We shouldn't be going and visiting with the interventional radiologists. And whoever might, if you really want to start a program like this, whomever we think might see those patients and want us to help them develop a program.
Well, I think that's a big difference with you being a owner of a perfusion company and, a group of staff perfusionists doing 126 hearts a month.
Right.
They're
Well,
gonna...
our situation is a little different than most guys. I mean, you're an entrepreneur more, so that makes more sense that you and busy.
Right.
Same with us. I mean, we're salary based with incentive tacked on at the end of it, which is good. We work harder than we're compensated over our salary, but there's a lot of groups, I'm not going to mention any, but one of these that they're quite satisfied with doing what they're doing and doing nothing more. And,
so John, you would be promoting this then? You would be interested in
for sure.
Because you're incentive based.
Right.
Because it's
we had that. Yes, we had that conversation.
Right. But we have that. We have a gain sharing program. We do have an incentive-based program to do this.
I'm not saying we don't.
No,
I'm not talking about us personally.
Yeah, no,
I'm saying we had the conversation that perfusionists, if you're just working and busy, and really what is your goal to go get more business, unless you're slow and then you're trying to find something to occupy your time.
That was what my point was going to be, is that what about those perfusionists who are working in a program and each one of them is doing, let's say there's two perfusionists and they're doing 140 cases a year, and then they lose one of their surgeons, and the surgeon that's left behind or recruit another surgeon that may not be that great, and now there's two of them and they just went to 60 cases a year, which is not enough for either of them to keep their certification. So how do we, as an industry and as an individual, take responsibility for that and figure out, because no one's going to help us. The hospital's not going to help us.
Right.
The surgeons aren't going to help us. They're fighting their own battles. Nobody is going to help us but us.
You need to find, I mean, I don't know, I had it written down somewhere, I did some research on this last night, but I don't know what the population is. They said it's the third leading cause of in-hospital mortality after cancer and...
DVTs?
Absolutely. Well, DVT, right?
DVT.
Yeah, from being in the bed and post-op, but especially cancer.
Cases, how many beds is your hospital? How many cardiac cases do you see a year? How many of these cases would exist in that? whatever that subset is.
Percentage-wise.
Whatever kind of hospital you were in. And then, I mean, I have no idea, like, where that number sits. But I'm guessing if you're a perfusionist in the hospital that's only doing 100 hearts a year, you're probably not seeing too many of these patients. I mean, I don't know. I mean, we're doing close to 1,000 hearts a year, and we've probably done, probably do like maybe like 15 or 20 of these in a year. So I don't know if you were in like a small 250 heart hospital or 100 heart.
Right, like a program with 60 hearts.
Right,
That's true.
but that's
That's a valid point.
That's a valid point, but the question that I would have, based on the numbers that I gave in my presentation that Dr. Ramchandani also reinforced in terms of the number of patients that have this as a problem, how many are not being identified where really
That's
in your
true.
institution you should be doing 4 and 5 times the number of cases that you're doing
Yeah,
and
That's
the
a good
program
point.
doing less.
That's a great point.
So I don't know, that's a good question, but I don't think we know the answer to that, which brings me back to...
identify them fast, within, your likelihood of success lies within the first 2 weeks. It has to be fresh thrombus. You can't get through that really hard. They have like an emaciation tool, though.
Well, I hate to interrupt your conversation,
Yeah, hey, Ray.
Hey,
but
I forgot you were there.
I'm losing a lot of this, so I'm going to take the rest of this offline, all right?
Ray, I'm sorry, you're not able to hear us?
No, not as well. I took my headset off.
Oh, I'm sorry. All right. Well, okay, so with all of that said, Ray, you got to do me a favor. You know what? Okay, need to get your address so I can send you this handsome cup, okay? And do you want it one that's new or do you want one that I've used? And then yeah, and then
It don't matter.
Okay, don't matter. Okay, well, we'll wash it, okay? And I don't have any really bad anything. I mean, I've got a few things, but nothing really horrible. And then we'll get you that cup. So I need your address.
What do you have?
And TB right now. And we appreciate you calling, but I want you to see if you can find some cases and you learn something more about this, about how to encourage or get people to do it, and you have some success in increasing your service line, please reach out to us and let us know what that was, because I think the rest of our colleagues are going to want to hear that.
All right.
Thanks, man.
Thanks,
Talk
Ray.
to you later, Ray.
Thanks, Ray.
All right. Thanks, Joe.
Which brings up that
Well-
this is not a benign. Go ahead. I'm sorry.
I was going to ask John a question. One of my big concerns when we did a couple cases is that, you see all of this clot, this little funnel's opening up, and I'm always worried how much is going around it and getting missed. If you see a big clot and then you're only getting a little bit in your filter, and then
I think there's a balloon there. It's not
so you feel like it captures, it should capture all of it and not start flying. Vast majority. But if
it's possible that some of it slips beyond that.
I mean,
I'm trying to think, because the native flow goes the other direction. If you're coming from the top, it would be going towards the heart, right?
Right.
I guess theoretically. I mean, that's probably why the last time we did that maceration tool, but it was in the lower.
Angiojet you're talking about.
No, we did it on that.
Oh, to macerate. Oh, to actually like.
Yeah, you said there's a tool.
It's almost like a rotor for the.
Oh, wow.
How they do them in the rotoblader, but it's not that strong. They don't
So we didn't have that, did we?
No.
We did not.
What our guy did
There is
was.
a shredding tool, but you got to be a little bit careful because, like you said, it can send a lot of shower of the small particles that theoretically get around there. And then, theoretically can travel your heart and then your lungs. And that would get down in your small lung vasculature, the little particles.
Right.
We didn't have an issue with it, though. I know they did use it a little bit to break it up. That was the case. Like, remember, I got 5 filters full of stuff.
Wow.
But the last case was a lot more successful. I think they identified that guy a lot sooner. And it was only 2, and then once they got a flow around, and they were able to, they did some ballooning and stuff, and we were good to go. I had full flow through his legs and stuff, so. And it was amazing the amount of swelling those patients have.
It is horrible.
Their entire legs are total.
Venous.
Crazy.
Like balloon ready to burst,
Yeah, venous insufficiency is ugly. I mean, it is really horrible.
We're just not used to seeing patients
right,
like that.
we don't.
So,
we just don't see them. Right.
Right.
That's a good point. So let's talk about the fact is that this is not a benign procedure, and without revealing who or where or anything like that.
You're going to give a case study?
We're going to talk about a case that we did. So I've done 2 cases with removing IVC filters, okay? Which the first one went fantastic. The second one, however, at a different place with a different person, they decided, and a lot of, even on the first one, the clot was, I mean, it was a lot of calcified, fibrotic, old, chronic stuff. There was some fresh stuff too, but a lot of really old, chronic, hard, rocky, bouldery type stuff. And what they did on the first procedure was engaged it from below, and then when it wouldn't toothpaste through, they call it form, and you'll see your line chattering, and then it'll suck and kind of pull it through before you engage anything.
Right.
So
that
that
should the flow, and then they should advance it.
right, but they
communication is always important.
right,
Yes.
but we would have you would see the flow go to 0 and knew something was on the tip, and then they removed the catheter with the flow, the RPM still up and block, and then once out, clamped it, got that boulder off, and went back in with it again, and did that a couple of times, and then they were able to actually establish flow around the filter, and they could see that it was no longer occluded or blocked, and then went through the top and essentially crushed the filter, and then were able to get it moved out. They would break the little legs on it, and ended up pulling it out, leaving this up top with it on high. And then if anything got stuck on it or anything like that, if it didn't come through, they would stop and pull it out and do the same thing, but nothing ever came through it. The other procedure we did, they put it in, they had it in through the top, they never turned it on. Everyone was screaming at them, you gotta turn it on.
And
Never
because
turned
he's
it on.
messing around.
And they went in there and they ended up taking the filter out, they fractured that filter as well, pulled the filter out, never turned this on. And
Why wouldn't you turn on the machine?
well, I mean, that's
He wouldn't
a really,
let us turn it
that's
on.
a really good question. Okay, so
Yeah, it's a whole device. That's what that's what you're paying
so
for.
Thank you, John.
moving the patient over to the bed to go to the ICU, they got unstable and rocky and not acting right, and then they kind of got better.
Well, remember they were like, "Ooh, the clot's gone. I don't
Yeah,
see
look.
anymore." And we're like, "Well, it's not in this filter,
Right.
so
It's gotta be the atrium.
exactly."
So took the patient to the ICU, and a few hours later, the patient was waking up and moved a little bit, became
an ECMO
obtundant,
patient, basically.
and essentially became an ECMO patient. Took the patient to the to the operating room. Went on full cardiopulmonary bypass and removed. And when you look at the images, which I don't want to show, the images of the filter that was taken out, and compare it to what was pulled out of the pulmonary artery, you could see it was like a puzzle. That's exactly where that came from, and of course the patient died. You know, so it's not benign. You have to use it properly. You can't just take this into your hospital and say, oh, let's just play with Angiovac. You really have to, and they are I think the company they have good and bad. On the good side, they have always sent a highly qualified, very informed, and very helpful clinical specialist that will work with the physician and work with you to do the procedure safely. On the flip side, there seems to be a disconnect that I'd like to discuss about who they are marketing this device to. Now, they've been very receptive to me in terms of coming to the New Orleans conference and getting more involved in perfusion, because I do think we can drive this, and I do believe they absolutely have to have us, but at the same time, I told you the story about them going into a hospital and they planned on doing this procedure and everybody's scratching their head, and I think the exact same thing happened to you.
John, do you remember when, John and I worked together in Detroit. Do you remember when they said, oh, there's an Angiovac? They told the surgeon, oh, you have perfusion, they'd have everything you need, you know, and we have all of our stuff. And then they got there and they're like, okay, well, where's your centrifugal pump head? Well, we run roller pumps here. We don't have that. You just told the surgeon. And I felt like there was a big disconnect of them sidestepping us to get it in the hospital. And then I felt like people are always saying perfusionists are reluctant to try new things. But it's more that you kind of shoved it on us, said you had everything you needed, and then you didn't, and we weren't prepared, and then we're like hesitant now, like, wait, what are we doing here? You know? Do you remember that at all? Maybe you weren't there. We worked at different hospitals, so you might have not been involved in that, but.
Yeah, I remember, no, I remember that instance though, but that doesn't happen, you know, where I work now. They pretty much.
It was very cohesive.
Yeah, I mean, they'd have to go to our group, they'd have to go to, and they'd be a big problem, I think, if they try to sidestep.
I would think so.
But I mean, I know there's other, you know, not groups, but companies that definitely market their devices, that in my opinion are perfusion devices, but they definitely go around. I'm not going to throw the company's names out right in front of the forum, but you know.
Yeah, we don't want to. So we don't want to.
Super users or whatever.
Is that because Joe always says that's because we're reluctant? Like they come to us and we don't do anything with it. Do you think it's that?
Perfusionists as a group, yeah. I mean, I can see that. I mean,
I can see it.
I'm not usually the forerunner and stuff like that. I mean, I'm not the chief perfusionist, so I'm not. You know, when something new comes on the market, I'm not going to run to the surgeon and like, hey man, I saw this thing on blah 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 or a meeting, we should give it a shot. You know, I'm not usually the guy to do that, but I mean. If they bring it into the hospital and say, hey, we want to try this, we want to try that,
then we'll do it.
More than welcome to do it, you know. And I think it's efficacious. And I think the biggest problem, maybe for hospitals, I don't know how it is for you guys down there, but like cost efficiency or effectiveness or however you want to call it, I mean, they're always looking at what a procedure costs. I mean, right now we're under heavy scrutiny for TAVRs, which I think is kind of insane, but you know,
I'm going to be talking about that next.
The cost of what it costs, you know, to have us stand advised. I mean, it's peanuts compared to like the risks, you know. But they're like, I don't know, can you guys stand advised, you know, just in case something bad happens. You're like, you got paid for it, like it's insanity, you know. And the device there, I think you said cost $17,000, so they might be like, oh, $17,000 for this. We got to get perfusions, we got to have, you know, C-arm, we got to have ANC.
Well, it's 13 for this.
Versus we'll just throw this guy with thrombolytics and whatever, see what happens in a week. You know?
Well, he was saying for TAVRs.
Oh, TAVR's more than 17.
For the valve.
I mean, the valve.
How much?
Yeah, I think TAVR's like $30,000. But I'm just saying, like, the hospital administration looks at like every little line item.
Right.
They're willing to like axe us or
Right.
nursing.
Save a little bit cutting out perfusion and spend a whole lot on the valve.
And they're like, oh, it's $17,000 for that versus you know, whatever some heparin or
well, they just
thrombolytics cost.
Well, thrombolytics are a lot more expensive than that. I'll tell you what. And
so what'd you say? This is 13.
13, not including the centrifugal pump. So add another.
Not including
add another $150 or whatever for a centrifugal head, and then whatever it costs for the device.
Cost analysis between this, you know, and the traditional route.
I know. Well, I invited John. I invited the company to participate in this so they could talk about all of that stuff, but they elected not, you know, and it's not because I don't think they don't care. I think they're really busy. You know, they're not really a big company, and I think they have a really cool device, which has a lot of utility to it, but, you know, I just think it's a time constraint thing, but it would have been really nice to have them talking. Now, you know, I'm not trying to plug the New Orleans conference, even though I kind of am, but we're going to have Dr. Jenkins from Ochsner, who is really good at this, and Angiovac or Angiodynamics is going to be there, and I'm sure that they would be able to contribute. And of course, we'll be videotaping that too. So the cost value analysis of this from a financial billing, CPT codes, DRG codes, all of that stuff. It is a surgical procedure. I mean, you are going to do a minimally invasive surgical procedure, intravascular procedure with veno-venous bypass. So, you know, the reimbursement on that is you know, not going to be low.
If you bill correctly.
If you bill correctly, but that's with everything, right? That's with everything that we do. There's a requirement for the surgeons to dictate and to list everything that you do in order to maximize reimbursement, no matter what it is. So I do think that they will help the hospitals with that. My personal feeling is that it is a value, both to the patient, getting them in and out of the hospital much faster, but also for the hospitals from a financial perspective, because having patients in the hospital day after day after day after day is, I think, I think it's much more expensive. But again, I'm not a billing or coding expert. Something we need to talk. So Min has joined us. Min, welcome.
Hi,
Min just got back from his vacation in Hawaii, so he was on the wrong time zone. It started at 7:50, not 9:50. But what's your experience? How are you? It's good to see you. Min Tran, CCP, everybody. You've seen him here before. What's your experience with this Angiovac? What are your quick thoughts?
I think it's a great tool that definitely perfusionists could use. That's, you know, something that's really not in our normal scope of practice, but, you know, at the same time, you know, we can implement it because we're very familiar with veno bypass. We can cut costs as far as like hospital stays. We can help treat the clot quicker, and also it is something that's unfamiliar with most practices. But I think if you have a team or maybe a program set up where you have enough experience and you possibly have a physician who can kind of be the backup with helping getting this started in a new program, and maybe even assisting with like going to different facilities to help with like training also too.
That's helpful.
I think that's real helpful too. I see that as really, you know, from my perspective, of course, I'm looking at it from, you know, none of us ever want to do something that doesn't bring value to the patient, that it's not, you know, going to be beneficial. You know, I mean, we all know what our ethical codes are. But, you know, with that said, if you really believe that it has clinical value and it can either increase the amount of revenue that you make as a department by doing these additional cases, help to stabilize a department that may be not too robust from a heart surgery perspective, doing a lot of TAVRs or whatever it may be, and that's kind of the way the program is built, or you're in business and your business is to increase revenue so you can increase salaries, so you can hire more people to reduce everybody's call, or, you know, you just as a business owner, you know, need a new airplane. You want to add these kinds of services, and when you see something that you think really has value and the data suggests that it does, and you're doing something that is beneficial for the patient and making money at it, you know, I mean, I think that's the best of all worlds.
Yeah.
Yeah, I agree.
You know, so Jennifer asks, she's at a university hospital and they do about 1 or 2 of these a year, which is very few. And
yeah, I'm surprised university, you think they'd be busier, you know, for doing this kind of thing.
You won't think. And and PTE cases are some of our most popular cases. So they're doing a lot of, so they must have some kind of pulmonary embolus response team, like we've heard people want to start, which I don't think is so easy. You better know what you're doing if you're going to do that.
Yeah,
that's
yeah, so they're looking for cases. And I was pretty impressed that you can put an oxygenator in this thing, kind of how they did that system.
Yeah, I got that written down here. I mean, that probably would work. You have to use 2 centrifugals. You wouldn't dare roll.
Right, 2 centrifugals.
Right in there in case the
heck no.
2 centrifugals.
clotted off or something, you know.
No.
You know, but but the problem is you're running, what's your flow, I guess you have to subtract flow, you could put 2 flow meters in. I guess you just say fucking, I'm sorry.
Oh.
You could just say.
Bleep, bleep. We know you're a perfusionist. That's great. It's great. Yeah. Oh.
How much flow is going through the venous side versus the arterial, but. You know.
I've said that a few times too, just not on the air. But that's okay. We'll fix that later. Okay. Right now, whatever. You know what? The number of people watching just went up. Okay, it's climbing. Yeah, you can have 2 bioheads. You can use the Revolution. You can use the Delphin. It doesn't really make any difference. You just need a centrifugal pump. I mean, if you wanted to use the Levitronics and spend a fortune, you could use that too.
John, you're a roller head place, right, for main arterial pump head?
Yeah, we use roller
so
head.
you don't
centrifugals for ECMO.
Right, so you have a lot of centrifugals.
Yeah, we use it. We're
I caught that when you said 2 centrifugals, not a roller head.
Right. Yeah. You have to.
You have
You got to use common sense.
Of course.
Well, I'd be surprised. Let's say. So I'm assuming that patient probably they try to get some of that clot out or whatever. I'm just theorizing here. And then for whatever reason, that patient's didn't oxygenate very well. I'm guessing. So they probably some of them went to lung, they were oxygenating well. They're like, oh, we better. Because I mean, if your cardiac standpoint went down, then you have to help out, the ventricle or whatever. I can't imagine that system helping you. They just want to provide oxygenated blood.
Just
somewhere.
oxygen. I think that's right.
I'm almost surprised they just didn't put it back venously, though. You know what I mean? Like, why
Well, of course, because they were going into
Because
the
it was
pulmonary artery.
open. They were going in and moving around.
Well, they were going in the PA. It was a pulmonary embolus. So I think they had hemodynamic instability as well. So I think they needed to bypass the right heart. So in that case, you're going to have to go back.
Probably a tricky
arterial.
case. Probably tricky.
Yeah, it probably was a tricky case, but
They were getting the lung, they were getting the oxygenated. That's when they needed the oxygen. Okay.
Yeah. So let me wrap this up if we can with this last little thing here. So I remember Stephanie and I I think you and I did the first case, and then Min, you did the second case that I had ever done. And we talked about this the other day in the when we were traveling, and of course I was just like, "Yeah, come on, let's just do this." And Stephanie was like, "Whoa, hold on a second here, okay? Whatever." And we kind of had to go a little bit back and forth. And I think I'm probably a little more cowboyish than you're a little more reserved and conservative, which is good balance.
I like to know things are going to work well, that there's a system, a plan. He's just like, let's go for it, let's try it. So he thinks I'm like that because he always gets me sucked into a lot of things, but I'm not. True.
And then you and I did the second one, and I was now experienced. See one, do one, teach one.
Right, now he's like, no problem.
Yeah, no problem at all. But in terms of support, how would you feel? And I think this is something that I want to say complimentary. I want to end up on a complimentary note with the company Angiodynamics because, as I said, I think they really have an interesting tool. I think that its utility is still, there's a lot of stuff that's known, but I think there's a lot of stuff that's not quite known. And I think with increasing amounts of FDA approval for things where they can market it, I think we'll see the use go up. But what are your thoughts in terms of the company's support when we did the procedures, both yours and the case that I did with you?
I thought that she was excellent to be with, and I would also say, for me, anytime I'm doing new things, having a second perfusionist there that you're comfortable working with is really helpful. So if you have the company to help you, another perfusionist to figure out the little glitches, then once you're comfortable doing it, you could do it on your own. Like you said, John, that 2 will help get it going right now, right?
Yeah, when we first set up.
When you first set up. Has your...
But the clinical specialists they sent are pretty knowledgeable. They're pretty helpful. They always show up, I think most of the time the cardiologist asks for them or the cardiac surgeon. We didn't really call them, but we just order the stuff. We can do it all by ourselves, so, but they show up and then they're there, they help out. They're good with all the ancillary stuff that, you know, they don't really have to tell us like how to run the machine or anything
Right.
like that. It's pretty self-explanatory.
John,
It's good.
has
Yeah.
most of your cases been like emergent, or it was
No,
like
no, they're
scheduled?
scheduled ahead.
Scheduled ahead.
A few
Okay.
days out.
What do you think, Min?
I think, yeah, I think the companies they've been very helpful, and I think having them there absolutely with a perfusionist would be, you know, in our best interest because they're the experts on this. You know, this is their product, and I think if you're in a program, once you're able to get enough clinical cases and practice and good experience on doing it comfortably, then maybe you could take that next step and not have
Right.
the rep there to do it, and just maybe have another perfusionist if the schedule permits and if you have enough on hand, because you never know what kind of troubleshooting, you know, you could get into with these cases, and since it's so new, you know, having two heads is better than one. To help.
Sometimes.
Sometimes.
It really does depend.
But if someone is trying to start this at their hospital
Yeah,
for
for a
the
new
first
program.
time, I think that you could comfortably say that you could reach out to the company and they will send clinical specialists and you could start a
And
program.
they've
no
been very
problem.
supportive, I believe.
I know.
Yeah,
I
definitely the first time you do it, they should, you know, definitely
Have
see
to be
somebody.
there.
Oh, I think it's
For
more
those
than
pure parties.
More than one.
I think it's more than just the first time, and really, I think the physicians need them
Yeah.
almost more than we do.
That's
You know,
true.
once we've figured out the
sure.
circuit, you know, it's not that hard. You know, I mean, I think from a technical perspective, but there are these little nuances. You know, like you know, when it gets stuck, knowing when it's actually sucking clot, you know, remembering that if you
Right.
have a hold of something and you're going to pull the catheter all the way out to clear it, don't turn the RPMs off until that catheter is out of the vessel,
That's all right.
or whatever you've got a hold of drifts back off and ends up, you know, creating havoc somewhere, you know, down the road. So that is critically important that I think, you know, there's just a lot, it's simple, but potentially very hazardous. It's kind of a dichotomy in that sense, I think. Well, John, I can't thank you enough for taking your time.
I appreciate it.
No, I appreciate